Right. Very good morning to all of you. I'm Preethi Dissanayake. I'm the president of the Ceylon College of Physicians for 2022. And it is a privilege to welcome all of you for the very first Young Physicians Forum and to be followed by the college lecture. This is a monthly program. This is the first for 2022. And it is my great privilege to welcome all of you for this program. The objective of this program are twofold: for the senior registrars to provide a platform to both showcase their newly acquired knowledge as well as enhance their presentation skills, which hopefully will take them a long way in time to come. Then, of course, the college lecture is usually reserved for one of the newer qualified consultants to share with us the very new insights they've acquired during their overseas training as well as with their work here. So those are the dual objectives of this program. And it is especially pleasing for me to actually chair this because back in 2005, I myself presented as a young physician at this forum and had the very great privilege of winning the Vijayarama Prize for the Best Young Physicians Forum presentation. So that has very fond memories. And 17 years later, I sit here as the president of the CCP. So hopefully the young presenters who present today will sit here maybe even less than 17 years and take over these organizations, right? So that's in terms of an introduction. So we will have the first presenter for today. That will be Dr. Preethi Dissanayake. She's a senior registrar in endocrinology. Preethi, may I invite you to come up? She obtained the MBBS from the University of Colombo with first class honors. She obtained the MD Medicine from the PGIM in September 2020, winning the John F. Stokes Gold Medal in Medicine. Her research and clinical interest is in endocrinology. She has presented and published in this area of research. And the topic for Preethi today will be the future of diabetes. Is there a cure? Over to you, Preethi.
Thank you very much, sir. Good morning, ladies and gentlemen. So, as the first speaker, today my task is to discuss the future of diabetes and try and find out an answer. Is there a cure? So, why are we so concerned about diabetes? Because we all know at the moment we are meeting two pandemics. One is diabetes and the other one is, of course, COVID-19. So why are we red zone? Belonging to the Southeast Asian region, we have an exponential rise in the prevalence and new cases of diabetes, and we are expected to have a 68% rise of diabetes by 2045. And not only that, what about the cost? 1 in 11 adults in our region have diabetes, and over 1 in 2 adults are undiagnosed about the disease. So, can we bear this cost? So, first, I will take you through a brief case. This is a common case scenario we all encounter. So, this gentleman, 28-year-old IT officer, is coming to you with an annual checkup. He has a blood pressure of 130/80 and BMI is 32. Fasting blood sugar is 145 and HbA1c is 7%. What do you think? He's coming and asking us, Doctor, do I have diabetes? Is there a cure for diabetes, doctor? Is diet and exercise good enough for me? Do I need to take drugs lifelong? What about the insulin? So, ladies and gentlemen, let's try to answer this man. So, in my next 25 minutes, I will be focusing on the definition of remission in type 2 diabetes, the mechanisms underlying the reversal, a brief review of evidence, and the challenges faced in practice. So, moving on to the definition. Diabetes, we all know that it is not a dichotomous disease. It is defined by hyperglycemia, which exists on a continuum. So, a group of experts got together in 2009 and formed this ADA consensus statement for diabetic remission. They discuss about a cure. Cure is restoration to good health. That means there is no disease afterwards. Usually, clinicians prefer using cure for an acute illness, for example, acute bacterial pneumonia. What about remission? Remission is abatement or disappearance of the signs and symptoms of a disease, of course, at the risk of recurrence later. So they thought that is the best term. And they categorized the remission into three: partial remission, complete remission, and prolonged remission. This is, I'm talking this in 2009, but there were lots and lots of controversies developed over the years, and in 2021, they developed a new consensus report defining diabetes with multiple experts all over the world, including oncologists. And according to this new consensus report, they discuss whether resolution, reversal, cure, whether they are better terms. Because all these terms means that there is no disease. But they thought remission is the best term. So, according to the current definition, remission they have defined as a return of HbA1c to less than 6.5. That is the cutoff for diagnosis of diabetes. That occurs either spontaneously or following an intervention, and that persists for at least 3 months in the absence of usual glucose lowering pharmacotherapy. So, if we can't use HbA1c due to certain hemoglobinopathies or other reason, we can use the fasting blood sugar cutoff, or in case if it is available, the estimated estimated A1C from continuous glucose monitoring. So, moving on to the mechanisms underlying the reversal, I will first see the three giants that we all know. In the pathophysiology of type 2 diabetes, we all know that there are these three singers get together and sing a bad tune for the diabetic patient. There is increased insulin resistance in the liver and skeletal muscle, and there is impaired insulin secretion from the pancreas because of the progressive beta cell failure, all of which lead to persistence of hyperglycemia. This is because there is progressive and we call inexorable exhaustion of beta cells. We all know that by the time we diagnose diabetes, 50% of the beta cell mass is lost. And 10 years from the diagnosis, 50% of them will need insulin. So what happens? Initially, this was thought that all these beta cells with the ongoing metabolic stress go into apoptosis. This is due to mainly advancing age, maybe the genetics or progressive insulin resistance, and because of lipotoxicity, glucotoxicity, both. But over time, this concept came that there is this ominous octet, that not only three singers that we talked about, now there are 8 people. So 5 new singers joined the crew. So let's focus on the adipose tissue. There is increased release of free fatty acids leading to lipotoxicity that gets deposited in liver, pancreas, and other tissues. And the incretin effect. We all know what is the importance of the incretin effect and what happens in type 2 diabetes, that there is defective incretin effect. And again, alpha cell, persistent hyperglucogonemia. during the fasting state will lead to increased hepatic glucose output. And the novel member is the increased glucose reabsorption from kidney. And the last is the brain. Usually, insulin should suppress the appetite, but in patients with diabetes, that doesn't happen. So, all get together and cause worsening of diabetes in the patient. This we need to know because if we understand this basic pathophysiology, we can act at multiple pathophysiologic defects and we can act early so that we can prevent the complications. So ladies and gentlemen, now there is paradigm shift of therapeutic strategy of diabetes. Earlier, it was glucocentric. That means we were only focusing about the HbA1c. Then we thought, no, we should reduce the cardiovascular risk. Then now we are in the era of cardio-renal centric. What about the future? So can we think about remission of diabetes? Before moving on to the remission, we should know how to reverse the diabetes. So what is the process? So there it comes, this twin cycle hypothesis. Roy Taylor and his colleagues got together and developed this hypothesis. I need your attention for this. So when there is chronic caloric excess along with developing peripheral resistance to insulin, there are two cycles working in our body. One is liver cycle and the other is the pancreatic cycle. So, we all know in the presence of positive caloric balance, there will be increased de novo lipogenesis that happens in the liver. So, increased production of liver fat gets deposited first in the liver, worsening the insulin resistance, and the insulin is unable to suppress the hepatic glucose production, further worsening fasting hyperglycemia. And that in turn will lead to fasting hyperinsulinemia. So with time, the liver can't bear this fat burden, so it spill over to the other organs. So this VLDL triacylglycerol go into pancreas. So the beta cells get deposited with fat and then comes the beta cell dedifferentiation. So initially we thought beta cells fail going ahead with apoptosis, but not only apoptosis, some cells can go in the direction of dedifferentiation. So they become empty cells or they can transdifferentiate into some other cells like alpha cells. And they drive the pancreatic cycle. There, what happens is they can't compensate for the postprandial glucose load. So postprandial hyperglycemia happens and that spin the liver cycle again. So this is the basis of twin cycle hypothesis, and in my next slide we'll discuss how to break it. So again, the same group of people thought, okay, sudden induction of negative calorie balance would reverse these cycles. So if we attain a substantial weight loss and maintain it, that will normalize the liver fat and that will reduce the pancreatic fat. So what will happen? If the cells are recoverable, then these two cycles are broken. And we can attain normal fasting insulin, normal fasting glucose, and postprandial glucose. So that is the basis for diabetes remission. This was again proved in numerous in vivo and in vitro studies where they studied the biology of the beta cells. So as I mentioned, this is the beta cell. Due to numerous genetic changes with the ongoing metabolic stress, some can undergo apoptosis, some can undergo transdifferentiation and dedifferentiation. But by bringing about this negative calorie balance or losing weight, we can redifferentiate these certain populations of beta cells. So moving on to the evidence, we all know about this study. This is one of the largest randomized control studies where they assess the effect of intensive lifestyle intervention among adults with type 2 diabetes. The main primary outcome was assessment of the cardiovascular disease risk, but that was a failure. However, as an ancillary observation, they found out that the substantial weight loss produced by the lifestyle interventions able to bring about this remission. So they achieved 6% of weight loss. With that, at 1 year, 11.5% of the participants went into remission and 7% remained in remission at 4 years. However, unfortunately, 1/3 returned to diabetes each year. Then comes this short-term insulin therapy. Intensive insulin therapy in the initial period of diagnosis of diabetes can reverse the beta cell glucotoxicity, and so they can recover the beta cells. So this is a very small study that they gave 3 months of insulin therapy and for 10 patients, and they found out that 50% went into remission. However, that is in 1986. But across the globe, there were multiple studies about this early initiation of intensive insulin therapy, and multiple systematic reviews and meta-analysis showed the marked improvement in insulin resistance and beta cell recovery, showing diabetic remission. However, the results are short-term. Now comes the famous fellow. This is the very low calorie diet we all talk about. So historically, very low calorie diet gained attention in 1970s with weight reduction strategies, and it usually consists of a liquid diet formulation containing 400 to 800 kilocalories per day. And they give this diet for 12 to 16 periods and achieve the weight loss, and then they reintroduce the solid food. This contains 50 to 60% of kilocalories from carbohydrate to prevent the ketosis. It contains essential fatty acids, high biological value protein, very little fiber, so patient can develop a lot of GI symptoms in the initial period, and it contains sufficient vitamins and minerals. So the use of very low calorie diet was checked by the same group of people, that is Roy Taylor and his colleagues in Counterpoint study. There, with the initiation of this diet, within 7 days, they noticed that the hepatic fat content fell in 30%. And within 7 days, there was improved hepatic insulin sensitivity and fasting blood sugar fell to normal. Thus, fasting blood sugar parallels hepatic insulin sensitivity. However, the beta cell recovery was a bit slow. It took 8 weeks for the beta cells to recover and for the return of first phase insulin response. This was again proved in the counterbalance study, where they all proved after 8 weeks of a very low calorie diet, they achieved a 15% of weight loss and 40% achieved remission in diabetes at 6 months. So they now got together and discussed who are the responders. Those who are younger, with shorter duration of diabetes, with lower initial fasting blood sugar and HbA1c like in our patient, and higher insulin level and lesser total fat mass. They had greater hepatic fat content, alkaline ALT, and insulin resistance. So both of the responders and non-responders had expected weight loss and normalization of liver fat content and insulin sensitivity as well as the pancreatic fat, but the recovery of the first phase insulin response was seen only in the people I discussed earlier. This was studied in a primary care setup. This is one of the largest trials in diabetic remission. They used 306 overweight and obese adults with recent onset diabetes, less than 6 years, in 3 phases. According to this study, they found that with the initial very low calorie diet, they achieved a marked reduction of weight. With that, 46% went into remission at 12 months and it persisted in 36% at 24 months. However, they also noticed that if you achieve more than 10 kilogram loss at 12 months, majority, above 50%, are in remission. This is diadem. This is the study. They again checked the same hypothesis in Middle East and North African community. They again proved the same thing where they found that remission was seen in 61% at 12 months and achievement of normoglycemia seen in 30%. What about the existing pharmacotherapy? There is existing pharmacotherapy improves beta cell function. This was studied in this RISE consortium, but effects last only as long as the treatment. If you can see here in the purple line is the liraglutide and metformin. They all achieved a marked reduction of HbA1c, but at 12 months when you stop all these medication, again it relapses back into the diabetes status. We all know about bariatric surgery, even though we are not in favor most of the time. But we have evidence for bariatric surgery or metabolic surgery over 30 years. All the studies, both randomized control studies as well as observational studies, showed that there is type 2 diabetes remission observed more than 50% or sometimes more than 60%. In those who achieve weight loss. And in about 80% of the people who undergo bariatric surgery attain good glycemic control. So these are the meta-analyses that show the remission rates. As you can remember, it is all above 70%. Here again, same. In the observational study, it mentioned the same. So how bariatric surgery remits diabetes? We know that there is reduction of weight, but that is not the only cause because we see the improvement of diabetes or the hyperglycemia within hours or within days of bariatric surgery. So it is not only the weight reduction, but there are multiple mechanisms. The gut, brain, and liver axis gets activated, and there are changes of the intestinal microbiome and bile acid flux, and many cytokines, chemokines come into play. So not only the weight reduction, there are multiple mechanisms causing this improvement of hyperglycemia. So let's see what are the challenges with all these interventions. So I discussed with you all about the very low calorie diet, existing pharmacotherapies, lifestyle interventions, as well as the short-term intensive insulin therapy. So what about the availability and feasibility in our setup? Is it available to all of us? And what about the patient acceptance and adherence? So will our patients be adhered to a very low calorie diet? That is a question. And will they accept early initiation of insulin therapy? Because we all know in our part of the world, there is great inertia for both patient as well as clinician inertia for initiation of insulin. And affordability. In our part of the world, again, bariatric surgery, whether they can bear the cost, whether it's available widely, that's again a concern. And the other concern is, we know as Asians, we have less BMI compared to the Western world. So majority of our type 2 diabetic population have BMI less than 33. So can we apply the same concept that they checked in all these studies? And almost always we have to keep in mind that there is chance of relapse and nothing is without risk. So what are the benefits of coding remission of diabetes? So I would like to ask a question. Would you like to be a diabetic? Are you all okay with that term? No. So, if we can come into a remission, we can remove the social stigmatization for our patient. And if we provide a target and a reward for the sustained hard work, which is usually necessary to achieve and maintain substantial weight loss, so we can keep the remission. And even though this is not a big concern in our part of the world, we all know the concerns with insurance and mortgages come into play a very big role in other parts of the world. And certain occupations, especially if we use insulin therapy, there are certain restrictions that also we can address. So, ladies and gentlemen, my take home message for today is diabetes, even though it's a chronic disease, can be reversed. But we can't cure diabetes at the moment. And long term surveillance is needed even after remission. We need to select the correct patient for remission. Not all patients. Let's say if a patient is coming after 10 years of diagnosis of diabetes, can we give him a false hope of remission? Of course not. So we need to correct the appropriate patient to undergo remission, and then we can proceed. And the other important thing is the best approach of management is starting treatment early, and we need to address the multiple pathogenic mechanisms in order to prevent all the complications of diabetes. So hopefully I think I have addressed all the questions of this gentleman, and thank you very much for the kind listening.
Thank you, Preethi, for the lecture. May I invite the judges for any observations or any comments, any questions, and thereafter we'll open the house for 5 minutes for questions. Do the judges have any questions or any comments to make?
Dr. Preethi, I'm Dissanayake, one of the judges. Are there any local experiences on these sort of interventions? Have there been any studies either locally or in the Indian subcontinent?
Sir, with regard to insulin therapy, of course, we don't have. But for bariatric surgery, of course, we have very much established data. Very low calorie diets we use for obese population, but we have not particularly studied diabetes remission per se. The problem is with our scientific evidence. Even though we practice, we have not documented, I think, in our part of the world.
I have two questions. One is about your patient. Would you still use insulin for the patient whom you have shown? Number two is, what about the islet cell transplant? Is that coming as a cure for diabetes?
Madam, islet cell, first I would address this islet cell transplant. It is not considered as an option for cure or remission in diabetes, in type 2 diabetes mellitus, because the data is scarce. But of course, in type 1 diabetes, we can discuss about the pancreatic transplantation and stem cell therapy and all. So that is why I didn't touch on that topic here. Your first question is, what was
your patient whom the case vignette you have shown?
Yes.
So would you consider insulin as an option for that patient?
In this patient, madam, of course, initiation of insulin is not only our decision. We need to discuss with the patient. With this recent COVID epidemic, we have seen many patients like this, but none of them are willing to start insulin, to be frank. So, of course, with his BMI, I would like to give him a chance, and we can start intensive lifestyle intervention, because these young people sometimes they go into a very good lifestyle adherence as well as pharmacotherapy. But of course, if someone is motivated enough to get insulin therapy, of course we can start. But what is studied in this research are continuous subcutaneous insulin infusions. For that will not be feasible in our setup.
Right, okay, thank you.
Are there any other questions from the audience? If there is no, please, if there is a question, you may ask. Otherwise, there is an online question which I will direct to Preethi. Anybody with any questions? Right, okay, it's coming. I'll have to see what are the that's a question from an online viewer for you, Preethi.
Sir, of course, with regard to dietary strategies, there are several diet plans. We all know that certain people practice their intermittent fasting. There are this keto diet, there are Mediterranean diet. However, what is studied and what is there in the literature is the very low calorie diet.
Right.
Yes.
Just one little question. Do we have to omit metformin also to call it remission?
No, sir. We need to take off all the medications to call it remission.
Right. Thank you very much, Preethi, for a very in-depth discussion as well as providing very clear answers to the questions. It's my great pleasure to present you with a certificate from the Ceylon College of Physicians.
Thank you, sir.